Good morning. I'm Dr. Steve Stites, Chief Medical Officer here at the University of Kansas Health System. Welcome back to Open Mics with Dr. Stites. You know, I'm a lung doctor by trade, and you've heard me talk on this program many times about a new drug for my cystic fibrosis patients called Trikafta. It's nothing less than a miracle. Before this drug was available, most CF patients barely made it out of their teens or really out of their 30s. Now, a patient born with CF today that can take Trikafta is forecast to have a normal life expectancy. Hopefully, we've been talking to them about starting to plan on retirement. They may be living up into their 80s and 90s. It's been one of the largest breakthroughs of my career and certainly one of the greatest thrills. Something very similar is going on in cancer therapy. More and more drugs are improving and extending the lives of cancer patients, and we're going to talk about one of those today that's targeted for prostate cancer. It's compared to a heat-seeking missile that can search and destroy prostate cancer cells wherever they are in the body. That is remarkable, and I can't wait to have that conversation. But first, we're going to talk about another, maybe even newer cancer therapy in today's morning rounds. It's another innovation in the exciting field of cell-based, here's a big word, immunotherapy. It's called TIL, or Til Therapy, for tumor infiltrating lymphocyte. We're going to talk about what that means in just a moment. It's an immune cell that can infiltrate and kill a solid tumor. Let's learn more about that from Dr. Gary Doolittle, an oncologist here at the University of Kansas Cancer Center, as well as the medical director of the Masonic Cancer Alliance, and a longtime friend and colleague of mine. He is especially excited because the first TIL therapy to get FDA approval is for melanoma, one of Dr. Doolittle's specialties. All right, Dr. D, help explain how TIL therapy works. Where do these tumor-infiltrating lymphocytes come from?
Well, good morning, Dr. Stites. I appreciate your interest in TIL therapy. Just approved by the FDA on February 16th, just a couple of weeks ago. I think you need to put this in the context of the treatment of metastatic melanoma, or melanoma that is spread throughout the body. 15 years ago, if you had metastatic disease, it was incurable, and the patient could expect to live between 6 and 8 months with standard therapy. Since that time, the whole field has been turned inside out with immunotherapy and drugs called targeted agents. And they have really made a huge difference in the impact in the lives of patients with melanoma. The challenge is we still have a long way to go. About 2/3 of patients with widespread disease treated with immunotherapy and targeted agents, we think may be cured. They certainly have a 5 and 6 year survival. What do we do with that other third? And that's where TIL therapy comes in. It's really remarkable. It's a new cellular approach to the treatment of cancer. And basically, we remove the melanoma tissue from the patient. So you remove the tumor. And within the tumor are lymphocytes, or body's immune cells, that locate in the tumor because they specifically go after the different proteins on the cells. So they're directed toward that patient's individual tumor. We remove it, we tease out the cancer cells, grow the lymphocytes in a lab, takes about 22 days. So those are the immune cells. We grow them into the billions, or at least a billion. Freeze them, give the patient chemotherapy, then give the patient those cells back, thawed, follow up with a medicine called IL-2, and we're seeing some remarkable changes in the natural history of the disease. Just FDA approved 2 weeks ago, so we're really excited about it here at KU.
When you say remarkable, tell us, what kind of outcomes are you seeing with that in the studies?
Again, I think perspective is so important because this is a population up until this point that has had nothing that works, and most of the time when immunotherapy fails the patient or targeted therapy fails the patient, we're looking at a matter of months. With this new cellular treatment, we can expect 40, maybe even 50% of patients to have a good response. And we know that at about the 2-year point, about 30% of patients are still alive with their disease. So while it's not a home run, it's the first step. And once we see something like this in the clinic, where people can actually attain a long-term survival when that was never possible before, it's the first step, and we're looking for newer studies, newer therapies, newer approaches in this population to change that percentage and make it even higher.
So just a couple of quick random thoughts. I mean, you and I have been in medicine for approximately a very long time together. And I remember the days of chemotherapy when we would give patients, we were excited when they lived 6 weeks longer. You just said that 2/3 of patients with melanoma are cured. That's remarkable.
It really is remarkable, and it's been so exciting as a melanoma specialist. In the last really 12 years, my career has been focused strictly on melanoma, and to watch it go from a disease where the best we could do was great supportive palliative care, which was very important at the time, and it's still important today, right? But that was the best we could do. To see it go from a disease like that to one that we expect to cure with immunotherapy and targeted drugs, that's amazing. It's still that population that where the drugs fail them, and that's the group that cellular therapy that's what we're going after with cellular therapy.
That's amazing. So it is kind of like a heat-seeking missile. Now, does the FDA, I mean, can we get, or be paid for the drug, or how does that work?
As you can imagine, any new therapy in the cancer space right now is extremely expensive. I think in the melanoma space, we're fortunate because there is a newer therapy called CAR-T, where immune cells are altered in the treatment of hematologic malignancies. So a lot of the expense issues regarding cellular therapy have been worked through because of that. So as we come into TIL, the jury's still out as far as how many companies are going to be willing to pay for this, but we anticipate that the majority are, because they now pay for this expensive other form of cellular therapy called CAR-T.
So it's pretty cool. Let me get this right. We take away some of your lymphocytes, we harvest them, we grow them in the lab, we reprogram them, we give them back to you, and they try to kill cells.
That's exactly right.
That's cool.
Yeah. When you remove the cells, the tumor itself is hostile to the immune system. So taking those cells out and removing the tumor cells and separating them from the immune cells, the lymphocytes, gives them a chance to become more activated. And melanomas are really unique. They produce a lot of different proteins on their cell surface. And it's those proteins that the immune system recognizes as abnormal. And that's why these cells are able to kill the cancer cells.
Yeah, that is amazing. Is it being used for any other solid tumors?
It is. It's in study for sure. We're seeing it in brain. We're certainly seeing it in lung cancer, which is the #1 cancer killer still in this country. So there's studies there. Cervical cancer, and I'm sure there will be more. I think we're just beginning to hit the tip of the iceberg when it comes to solid tumors and cellular therapy. Melanoma was a natural place to start because it tends to be a disease that is sensitive to the immune response. So taking these immune cells and starting in this disease made a lot of sense. But we know from immunotherapy in the other disease types, many solid tumors respond to immunotherapeutic agents. And if that's the case, then we would anticipate they would respond to cellular immunotherapy approaches.
Well, Dr. Doolittle, this has been remarkable. Thank you so much for being part of this program. I got to tell the audience, hey, listen, I knew him when he used to have red hair, and I used to have hair. It's been a while. Thanks for being on the program today. This is remarkable. We're going to devote an entire episode to TIL therapy in the spring. We can look forward to an in-depth discussion at that time.
It's been a pleasure. Thank you.
Thank you. Thanks for being here. All right, we're going to turn now to prostate cancer. Every urologist I know says the same thing. If a man lives long enough, odds are they'll get prostate cancer. I'm one of those guys. Many men end up needing surgery or radiation. If the cancer is slow growing, it may not need treatment at all. And then there are challenging cases where the prostate cancer is metastatic, meaning it is spread to other parts of the body. I know I'm pretty lucky. I get to be in that group that doesn't have to do anything and just watchful waiting. But man, that part where it has metastasis and goes to the other part of the body is a bigger challenge. And today, we're going to focus on a new tool helping patients and physicians face the challenge of metastatic prostate cancer. Joining me today is medical oncologist and medical director of palliative and geriatric oncology services, Dr. Elizabeth Wolfe Birchfield with the University of Kansas Cancer Center. Okay, here's a funny story. I used to know her as Libby. She doesn't remember that. I do, because her mom is Diana Dark, who was one of my mentors and instructors when I was a pulmonary critical care fellow at KU many, many, many years ago. So welcome onto the program today. We're delighted to have you.
Thank you. I'm so glad to be here.
And say good morning, and say hello to your mom for me when you see her again. We're going to also hear from John Corbin, who's a prostate cancer patient of Dr. Wolf Birchfield's, later on in this program. Doctor, let's start with you and let's get basic. What does the prostate do? And why do we have to have it as guys? Because it's just painful.
Yeah, the prostate is a male organ that produces a fluid that, in combination with semen produced by the testicles, or in combination with sperm, creates semen.
All right.
That's what it's for.
And is there a typical age range when most men are diagnosed with prostate cancer?
Yes, so most cases of prostate cancer are diagnosed when patients are in their 60s, but I have patients who've been diagnosed in 50s, 40s, and even 30s.
Yeah, and I know it can be a familial disease, like it's a familial disease for me, and I'm always nervous about my son, and when does he have to start getting screened? So touch us a little bit about the familial part of prostate cancer.
Well, so prostate cancer some folks get prostate cancer as part of an inherited cancer syndrome, and sometimes we don't even, there can be a familial component even if it's not with a named or well-known syndrome. Yeah. So it's really important to do enhanced screening for anyone who has a family member with a history of prostate, breast, ovarian, or pancreas cancer.
Yeah, I know, like that BRCA2 gene can be one of those, so it can be difficult. They have to start getting screening a lot younger. Prostate cancer is usually slow growing. How do you first treat it when it's diagnosed?
Well, what's interesting is, as a medical oncologist, folks who have slow-growing prostate cancer really never need to see someone like me, or rarely need to. So when
I'm hoping I'm going to keep staying right there.
Let's keep our interactions like this rather than in my clinic. That's my goal. So I would say, when prostate cancer is localized, then sometimes it doesn't need any treatment. It can just be observed closely by a urologist. But if it's localized and needs treatment, then that can take the form of radical prostatectomy, radiation, and sometimes radiation is given with concurrent androgen deprivation therapy or medical therapy that lowers testosterone levels.
Okay, you're going to tell us what androgen deprivation therapy is.
Yes. So these are medications that essentially tell the brains to tell your endocrine glands to stop making testosterone. So it's treatment that is supposed to turn off the testosterone factory.
There's been some discussion that people who take testosterone, men who take testosterone replacement, can be at an increased risk for prostate cancer. Talk to us a little bit about that.
Yeah, I think that's not completely known, because if someone has a low testosterone level and then they take treatment to get them to a normal testosterone level, then it shouldn't really be any different than normal male physiology. Right. I think in the space of folks who have a diagnosis of prostate cancer and are post-treatment, there's active work going on right now to see if replacing testosterone can be safe for those men. So I would say that's still really under investigation, but in theory, if someone has a normal testosterone level with treatment, then it shouldn't be different than other times.
So let's talk about this new medicine called Pluvicto.
Sure.
Yeah, it's what's known as a radiopharmaceutical, as in radioactive, not radio that's going to broadcast a signal. So it involves this kind of radioactive material. Tell us how that works.
Well, these are such important treatments that have existed with certain cancers. So this is a radioactive particle called lutetium-177, and it's attached to a drug called PSMA-617, and that drug delivers the radioactive particle to cells that express PSMA, prostate-specific membrane antigen, which is prostate cancer cells. It's actually expressed more highly in prostate cancer cells or on prostate cancer cells than it would be other normal prostate cells, but other cells like salivary gland tissue actually express it too. But in taking the radioactive particle directly to the cells and binding to the outside, it's brought in the cell, and then the radioactive molecule or particle destroys the cell just like it would with external beam radiation.
Wow, that is. How does it kill the salivary glands too?
It often has a pretty big salivary impact. Unfortunately, permanent dry mouth is common for most people who get this drug.
Okay. How does it compare to more traditional treatment options for metastatic prostate cancer?
Well, so it's been compared in terms of effectiveness and in terms of tolerability, and it wins out in both categories. So it's been compared to either receiving a different hormonal agent versus Pluvicto, and it was shown to be more effective and have better cancer control, a delay in time till patients might have symptoms from their cancer, and longer survival. And then it's also been compared to chemotherapy and has been shown that it has fewer side effects and it's just a more favorable experience for the patient than conventional chemotherapy.
All right. So you've mentioned the side effects about the dry mouth. Are there other side effects we should think about?
There are. I will say I think now and forever fatigue will probably be the most prominent symptom of any cancer therapy. But generally speaking, it is a lower degree of fatigue significantly than what folks experience with chemotherapy. So fatigue, dry mouth, it can cause low blood counts and therefore could increase the risk of infection. It can cause self-limited nausea and self-limited diarrhea. And then there's a very rare side effect that it could cause kidney stress, but thankfully that's very, very rare.
Yeah, thankfully. So how often does a patient have to get the treatment?
They can receive it every 6 weeks for up to 6 times if they're continuing to benefit and if their body's tolerating it well.
Is it a cure?
I wish that I could say yes. I think that someday it probably will be proven to increase the chance of cure. Right now, it's being offered to men who have metastatic prostate cancer that's taken root in other parts of their body and who have had not only androgen deprivation therapy, so testosterone lowering treatment, another hormone treatment, and chemotherapy. So this is patients whose cancer has already seen a number of treatments. So right now it's not a cure, but there was some really exciting research presented in the fall of 2023 that showed that even in folks who have not had chemotherapy yet, that it seems to be maybe work even better. So I think we're going to see this and sister drugs.
Therapy.
Actually second line, but still, because right now it's third, but I think we're going to see this and sister drugs or sister products move up and up and up. And I wouldn't be surprised if it was in the curative intent space as kind of a cleanup treatment at some time.
I love that thought. So we have a video of one of your patients receiving Pluvicto. Let's see if we can take a look at that. Talk to us a little bit about what we're seeing here. Yeah,
so this is one of my absolutely wonderful, beloved patients receiving treatment. He is receiving it through a peripheral IV. And even though it is, a radioactive particle, it's given in the form of a medication. So it's something that's injected slowly. Right now, it's by our colleagues in nuclear medicine. It can also be given and is at other institutions given by radiation oncologists, and we hope that we'll eventually be able to give it in multiple locations just to increase opportunity for patients to receive it, just to have more slots for patients. So it's a pretty, as you can see on the video, it's a really controlled setting. It's not scary. It doesn't feel like a spooky science fiction experience. It feels like many of the other treatments he would have received. It's a pretty low-key experience, thankfully.
Do you see this as becoming kind of a standard of care for this, or one of its companion drugs becoming kind of the standard of care for prostate cancer?
I mean, I would say it already is a standard of care in the setting in which it's approved. I think absolutely it will continue to cement itself in the standard of care, as well as some other products that are being investigated and might have different uses, before or after Pluvicto, but Pluvicto is first on the scene. It's a crucial standard for our patients already.
Yeah. So as you look at it, we're talking about metastatic prostate cancer. But could it be used in just regular prostate cancer, or that's not metastatic, to help make sure it doesn't become metastatic? Is there any role for that?
Right now, there isn't any proven role, but that is going to be investigated. With any new cancer therapy, we offer it to the folks who need it the most first, and that's people who already have advanced disease. So we've done that. We've actually moved it, quote, up earlier in the advanced space instead of getting a secondary hormone therapy before chemotherapy. I think it's going to move in the first line. If we demonstrate that it improves outcomes as a first-line treatment for advanced disease, then I absolutely think it will be investigated. And I would envision that it could have benefit in someone who maybe has a prostatectomy and has high-risk disease for recurrence, and similar to the way, or maybe augmenting the way that we use radiation for those patients now. Generally speaking, for radiopharmaceuticals, it would be difficult to use this as the only form of treatment because it has to penetrate every cell to cure the cancer. So the idea of getting it all the way into every single cell that's making up a tumor would be a pretty big ask for a medication. But I think thinking of it as kind of a cleanup treatment, similar to the way that we use radioactive iodine for thyroid cancer now, I think it's possible.
Similar to my wife saying, Stephen, clean up after yourself. You need to
There
do
we go.
That's probably the right
You're a
play.
leader.
I don't know about that. I'm not sure you agree with that. So, as you step back and you think about the lives of prostate, I mean, again, we talked about being in medicine a long time, a little bit ago with Dr. Doolittle, and this prostate cancer has come so far already. What's the future look like to you?
Well, I think the future looks like using radiopharmaceuticals as combinations. I think that's going to happen. We're seeing the beginnings of that. I think we're going to see that more. And I think another really important task is going to be for us to find a way to harness the power of the immune system, just as we do with melanoma. Unfortunately, prostate cancer is considered an immunologically cold tumor. So it's something for which immunotherapy has largely been unhelpful. There is actually an approved vaccine-like treatment, but it has pretty limited efficacy. It has benefit, and I'm not trying to suggest people shouldn't receive it. It's just that it doesn't have anywhere near the benefit that immune checkpoint inhibitors, CAR T-cell therapy, high-dose IL-2 cytokine therapy, Til therapy has shown in these other cancers. So one of our main tasks in the field of oncology and genitourinary oncology, like what I practice, is to figure out how to harness the power of the immune system. And then I would also say another important task, which relates to some of what I do, is figuring out how to de-implement or just minimize exposure to androgen deprivation therapy. For men to have the experience of living without testosterone is a life-altering experience. Even if their cancer is cured, we are learning more that the longer people are on those treatments, the lower the chances that their testosterone will rise back to normal levels. And while I do think my patients find a way to live well with their new life, it's a new life, and what they would prefer is to live a life most similar to what they had before. Yeah. So I think those are all some of the things that are most urgent.
Yeah. So what do you do with that dry mouth?
What do we do with dry mouth? Well, it's the same thing that we do with dry mouth from other cancer therapies. So largely we have patients use mouth moisturizers. Dental care and hygiene becomes extra important. Without saliva, we lose a lot of important molecules and compounds that help prevent dental decay. So being extra diligent about dental care. I actually prescribe my patients Prevident, which is a high fluoride toothpaste. It's not standard, but I do just as I would if they had neck cancer and had dry mouth. There was some data presented over the past year or two at the American Society of Clinical Oncology that for patients with head and neck cancer with radiation-induced dry mouth, that actually acupuncture, even for patients who had dry mouth for a long time. Really? And it was a beautiful trial that had a sham control for acupuncture, which is very hard to do. Still use needles, and it showed benefit. So I think that we might even see acupuncture come into play. Right now I would not consider that standard because we don't know about this cause of dry mouth, but for folks to have had dry mouth for up to 14 years and participate in that trial and then benefit from acupuncture is pretty incredible. Anytime we can avoid using a drug, that's always better. I want my patients to have their body in the most natural state possible. So just really good dental hygiene, mouth moisturizers, sugar-free lozenges, lots and lots of water.
All right, excellent. Okay, well, we're here to answer your questions. Send them using the links on your screen from YouTube, Facebook, Twitter, or email the Medical News Network. Let's check with the COVID count with Dr. Dana Hawkinson, Medical Director of Infection Prevention and Control, Hawkeye, here at the Health System. Hawk?
Hi.
We're doing pretty good.
We are better than we had been. Yeah, 15 active inpatients, so down from those low 20s that we've seen the past few weeks. So overall, I think that's good news. Hopefully now we are starting to see a little bit lower circulation of not only SARS-CoV-2 in the community, but also those other cough and cold respiratory viruses. But we know they are still out there. We've heard anecdotes, friends, other news stories just about other coughs and colds that are going around that are not the big three. So they are still out there, but hopefully we are moving now out of respiratory viral season. Again, remember it does go till about April, so we still have about a month.
Well, let's take a look at the admissions over time. The green bar is getting a little shorter, the COVID bar.
Yeah, absolutely. You know, the green bar is down, and again, just as I said, the last few weeks we've seen it a little bit higher in those low 20s. We are seeing it come down, but also, Steve, those other illnesses, influenza as well as RSV, are coming down as well. So overall, that is good news. I think we have another graph as well, just overall looking at the amount of influenza-like activity that people are going to for, they're going to primary care visits, emergency departments or urgent cares for influenza-like illness, which is any of these cough and cold viruses. So you can see that middle line right there, it's kind of red, it's plateaued. It is down from a peak. Hopefully we won't see another peak. Hopefully this plateau will stay or even decrease in the next couple weeks as well. So overall, good news, influenza activity overall in most of the nation is down as well.
We like that. And we know sometimes it pops back up in March, and we're going to cross
Yeah.
our fingers and hope it doesn't. Overall, not a terrible flu year.
No.
Always difficult, but not terrible. And COVID a lot less. And with the RSV vaccination, I think that's been a big help to our pediatric colleagues especially.
Yeah, I would say the RSV vaccination has helped greatly. Pediatrics, you know, for the mothers, they can get that dose of vaccine that then has the mom's immune response create antibodies. Those antibodies are transferred to baby, but also we have those adult vaccines as well, which has helped. So I think overall that is good news. There was some early additional Canadian data looking at the efficacy of the COVID updated vaccine as well as influenza vaccine for this year, and it did look to have good efficacy for helping reduce people's risk of hospitalization.
You know, the big health headline is measles and how Florida is choosing to handle an outbreak in a Miami area middle school.
Yeah.
The Surgeon General there has been critical of vaccines before, is taking a hands-off approach and not recommending that parents keep unvaccinated kids at home. 8 cases at the one school.
Yeah, so far 10, 8 cases have been linked, but even one of those new 10 cases, again, they're still investigating the rest of those. One of those cases is in a child under 5 as well. So, you know, it's just unfortunate that there is a mass platform for this type of non-medical, non-evidence-based guidance, probably based more on opinion than anything. We know measles can affect people. We have had the luxury, though, of understanding that there has been measles vaccine for quite some time. So most of our generations have not seen the effects of that, either the acute illness, but also remember you can have even illnesses or effects years afterward. But remember, measles can, 1 in 5 people can go to the hospital. 1 in 20 can get pneumonia, which can also be a secondary bacterial pneumonia. And then 1 in 1,000 can get central nervous system or brain effects. Those can also be lifelong as well. But we should mention that one people don't understand this is measles is a lymphotropic virus. What does that mean? That means it does go to the lymphocytes. Why are lymphocytes important? They are a major part of our immune system. So what that does is knock out those cells so you can have a reduced immunity or some sort of immune suppression for even up to 2 years after you have your infection. So that is one of the other reasons why measles infection is so dangerous.
You know, I'll pick up on that thread you mentioned that you and I have had the luxury of having people get their DTaP and their MMR and all those things and their polio vaccine, and now people are talking about not vaccinating. You know, if you've been in medicine, again, it's not like my 4th time I've mentioned how long I've been in medicine today. I didn't forget that I've said that. Early in my career, I would see patients who'd had polio prior to the polio vaccination.
Yeah.
And they had lived, they didn't die at the polio at the time, but so many of them had lifelong challenges resulting from that. A paralyzed diaphragm, one limb or another not moving as well, or to your point, the lifelong effects of encephalitis, which can be especially damaging because it's an inflammation of the brain, it can leave with permanent damage. Hawkeye, this is not something to be trifled with politically, and yet it feels like it has.
Oh, I think it 100% has, and that is kind of consistent with other decisions made by this particular Surgeon General. I think it is important to understand that why are we putting that risk upon these children who have no ability to make these decisions for themselves when we know these vaccines prevent the disease, prevent the side effects of the disease, and most importantly, like we've always said, are extremely safe. You know, there was another popular person who was on a late night talk show recently who commented on why are we going back to these old ideas? Why are we continuing these old ideas? Old ideas that that medicine doesn't help or we don't have good medicine. This is one of those things as well. Why are we going back in time pre-1957 or 1956 when these vaccines were available? When we saw the devastation and the physicians and the families saw the devastations these vaccine preventable diseases were causing, why would we want to go back and do that? I think it's vitally important. Protect yourself, protect your kids. There still is time to get influenza and COVID update vaccines. There's still a time to get measles, mumps, rubella vaccine. You can actually get vaccinated 72 hours after exposure and still develop protection from these diseases as well.
You know, it's like people have gone to the dark side here and they just don't want to look and see the truth. They want to see what they want to do for whatever their political belief is. And it's unfortunate that science is out here with all these facts and all this experience. And again, for those of us who have seen the side effects of these diseases prior to that affected people prior to vaccination, you know, it's just not something you should be playing with like that. It's not fair to folks across the country just to ignore the truth and the facts. All right, we know you have many questions. Let's head to Studio B with Alexis Del Cid. Alexis, good morning.
We have some fantastic questions, doctors. First, we have a shout out from Kathy Cook to Dr. Wolf Birchfield. Kathy writes, "We are fans of Dr. Wolf Birchfield's care." So you've got some fans out there, obviously.
Awesome.
Have a question from one of our faithful viewers, Ruth Ellen. It's interesting. She wants to know, do genes ever become less predominant with future generations?
Well, with genetic diseases, sometimes do become less impactful with subsequent generations. Sometimes they actually become more. It just depends. Right now, with the genes that are known to be associated with inherited cancer syndromes, there isn't really evidence that there's kind of a washout effect with time. So we think of it as still being just as impactful if someone's the first family member to be diagnosed with that gene mutation, or if they're the third or fourth generation, which could happen now with availability of testing.
Yeah. Jean Reardon has a question. Jean wants to know, what's the treatment for permanent dry mouth, and does this work when the cancer has spread to the bone?
So Pluvicto does work when cancer has spread to the bone. In fact, most patients who receive Pluvicto have bone metastases from the cancer. Permanent dry mouth is treated supportively. So it's treated with, mouth moisturizers. A brand example would be Biotene. So they make sprays, they make lozenges, and some things like that. Xylomelt is another example, which is a sugar-free lozenge that can kind of create a little bit of a layer of xylitol on the tongue and in the lining of the mouth to create a feeling of more moisture. Lots and lots of water. As I said, I think we might hear that using acupuncture has a role, but in terms of dry mouth caused by prostate cancer treatments, we don't know that acupuncture is helpful at this time. I want to be clear about that. But in some other populations, like folks who've had head and neck cancers, who got dry mouth from their head and neck cancer treatment, acupuncture has been shown to be helpful.
Stu has a good question. Stu shares, I know my dad had prostate cancer, but I don't know exactly how old he was when he got it. I'm 34 now. Should I get my PSA tested?
So, and this is something I certainly would recommend for you to, every person to talk to their own medical team about. And I think it's never wrong to seek consultation with a urologist or with a primary care provider to discuss the guidelines. For folks who are at high risk, actually there are updated guidelines that recommend screening at age 40. So again, I think it could be different depending on if it's possible to figure out when someone's parent was diagnosed. If they were diagnosed at 40, then we would start earlier. However, now for men who identify themselves as Black or African American, and for folks who have an increased genetic risk, age 40 is when prostate cancer screening is recommended now.
Jeremy Yenser wants to know, when a patient is coming to you for the first time in the beginning of their treatment, what are the most common concerns you find that they have?
Well, the patients who I see in my clinic typically have high-risk prostate cancer, or they have metastatic prostate cancer. And so for those men, my role is to describe a lot of what systemic or medication type cancer treatments include. So that most people want to know about what's the likelihood of the cancer getting under control, what's the likelihood that we can eradicate the cancer and make it go all the way away forever, what is the cost in terms of sometimes financial, but sometimes to quality of life and overall well-being? What are the trade-offs of treatment, and what are different paths that have been shown to be helpful? So all of those questions come up during a first visit, and not just during a first visit. A lot of those questions we talk about multiple times because they're really high impact and they need time for breathing and consideration, and so those topics come up multiple times.
We have one more. We've had this a couple of times. Betsy and a few other viewers want to know if insurance covers this new treatment.
Yes, a very important question. I'm happy to say that insurance does cover this treatment, and we have a wonderful team of financial counselors who work on pre-authorization for the treatment to make sure that we have that approval in hand before going into the treatment. So thankfully it is covered by insurance. It's not experimental, it's not investigational, it has proven benefit and FDA-approved treatment, and it's covered by insurance.
I want to thank Dr. Elizabeth Wolf Birchfield. I even said it right again, I think, from our University of Kansas Cancer Center. Yeah, I don't know about gold stars, but she is the Medical Director of Palliative and Geriatric Oncology Services here at the University of Kansas Health System, and delighted to have you on the program today, and delighted to learn more about prostate cancer. And a special shout out to all our patients out there and all the people who are out there listening. Make sure you get screened, especially if you have that family history. Don't let this sneak up and get you. Let's go around the table and just ask for final thoughts, and Dr. Elizabeth Wolf Birchfield, I'm going to start with you.
Well, I agree that screening is essential, and I think it makes a difference to work with an academic team of oncologists who have access to some of these latest treatments like Pluvicto. We are the site that has this in our community, and so we're happy to see you. We are here to serve you, and it is a scary time, but we are here to serve you and meet your needs and offer you the latest and greatest that medicine has to offer.
Doc Hawk.
Yeah, if you don't get a gold star, we can always give you gold shoes. But
oh, and by the way, Hawk, what happened last night? The Hawkeye. The Hawkeye.
It's sickening. It's hard to stomach, man. I get hurt when my Jayhawks lose. So,
yeah.
I know head coach Bill Self will turn them around. It's been a tough, conference season, as evidenced by the record, but I know they'll pull it together and be well, and we still have a few games left of the regular season, and then on to the tournament. So, yeah. Again, I think it's vitally important. Be updated with your vaccines, or be up to date with your vaccines. We have these childhood vaccine preventable disease vaccines for a reason, because they do work, and most importantly, they are safe. You have time to get them. Protect yourself, protect your loved ones, and just please be up to date with those vaccines.
I want to thank all of our guests here on this program today. What a great program it's been, and it's just been terrific. So thank you for being here. I just want to point out that as you look across the spectrum and the discussion you see in Florida and places like that, we also have to pay heed, not to all who enter the Fog Island, but also to all Island Villas, but to all the science and all the time that has gone in front of us, and all the experience that many of us have had in taking care of patients with diseases that we can now prevent with vaccination. Be safe out there. Be thoughtful. Be honest with yourself. Let's be honest with each other, because with faith, hope, and science, we can deliver things like Pluvicto and tumor-infiltrating lymphocyte therapy. What a remarkable story this morning has been. Thanks again for all of our guests, and thanks to all of you.
A local drummer skipped taking care of the most important beat, his heart. I'm Alexis Del Cid. On the next All Things Heart, what he ignored that ultimately led to a quintuple bypass.
Subscribe to our morning medical update and open mics with Dr. Stites podcasts. Now everywhere podcasts are available.